Okay.
Good afternoon, everyone, and welcome to the 6th episode of our Medical Education Clinical Reasoning program. We are pleased to meet you all again, and we hope that you are enjoying our series so far. Let us start this episode by introducing our panelists for today. Our clinical advisor is Dr. Asha Al-Ma'mari. Today's resident is Dr. Wadah, and of course, our two case discussants, Fawaqi and Maryam. We'd use this time to allow our speakers to briefly introduce themselves. So we can start with you, Dr. Asha.
Aisha Al-Ma'mari, Consultant Emergency Medicine and Critical Care.
اوكي السلام عليكم ورحمة الله. وضاح السرحي، emergency medicine resident R4 توام hospital.
السلام عليكم، مريم من نعماني 6 year medical student.
Assalamu alaikum. My name is Fawaqi Ali Robari and I'm a 6th-year medical student as well.
Thank you all for this introduction. I would like to use this opportunity to remind our audience to leave their comments and questions in the chat box for us to address them later on. With that, let's leave the floor to Dr. Wadah as he walks us through today's case. Dr. Wadah, the floor is yours.
All right, thank you very much. So this is a patient which we had last week in our resuscitation room. So this patient was a 40 years old male. You received a call from the EMS stating that we are bringing a patient who is 40 years old male who sustained RTA with multiple rollover and is expecting critical injuries. So I'd like to Dr. Maryam and Dr. Fawaqi to just go through it. Let us see what will they do, how they approach this case, and we can help them over and guide them and see what should be done and what should we how should we approach this case. So Dr. Maryam or Dr. Fawaqi.
Okay, so we have a 40 years old male and he sustained the RTA with multiple rollover. Like, do we have a specific information about the injury itself?
No, they were seeing just multiple injuries, mainly in the chest, and yeah, that's it. We didn't have much information. There's just multiple critical injuries.
Okay, Dr. Wadah, I want to know more about the status of this patient. Is he awake or is he conscious or did he lost consciousness after this happened?
So we are not yet aware. The patient is still with the EMS, and we are and you are on the resus. You are the team leader, and so what you can do meanwhile before the patients come to the resus. Do you want to do anything?
Okay, I wanted to activate the trauma code. The team can be here by, yeah.
We also need to have like an empty room in the recess with all the equipment are well functioned in case we need it. We also need to inform the general surgery, the anesthesia, the radiology department that we are suspecting a severe trauma case, and they all need to be ready when the patient comes.
All right. So yes, first point in this multiple trauma patient, as you said, we have to prepare ourselves, prepare our team. So preparation includes team preparation, which is like assigning the roles for the team. You have to know who is with you and assigning their roles. The second point is to have to prepare your equipments, which include like blood products, warmth fluids, airway management if needed. And the third preparation include your protectives, PPEs, which should be like face mask, eye protection, surgical gown, and gloves. The point regarding trauma team activation, usually we don't activate trauma card before we see the patient and assess the patient. Because as you know that EMS, they said it's yes, multiple and it's multiple trauma, but we are not sure how severe is it. Maybe it's just some mild, maybe it's so all right, so you prepare your team, you assign the roles, and Now, what team members you want to assign, or how do you assign them, or what is your minimum number of the team you want to assign? Can you tell me?
We can assign minimum or 4 to 5 members. One of them has to be the team leader, and then one for the airway, one to check for a primary survey, and one to document.
All right. Okay. So yes, as you mentioned, and as per the ATLS, there should be a team leader. There should be an airway, and who's taking care of the airway and sequeller. The other one should be taking IV medications and take blood investigations. The other one should be recorder and doing the takes history maybe from the EMS, and one should be for the primary survey, which is usually breathing and circulation. So good. Okay, so you prepare your team, you prepare your documents, and you assign roles, and you wear your PPEs as a team leader and the team. So now patient arrived to you. So on arrival of the patient, what will you do first?
Check the airways.
Okay, so before going to examining the patient, as we know, it's a principle in the ATLS that hand over, hand off. So first of all, you don't touch the patient, you just take handover from the EMS and swift transfer patient to the bed or to your room. So the transfer include what we call the MIST, MIST, this mnemonic, which you ask the EMS about the mechanism and time of injury, injuries found and suspected, symptoms and signs, and treatment initiated. So by this way, you cover the most important things from the EMS before they leave. So patient came to you, you took the MIST, you asked about the mechanism, the injury, symptoms and signs, and treatment initiated, and then patient transferred to your bed. So what will you do next before going to examine the patient?
Okay, after that, I think we want to
Yes.
we want to listen to the team leader what he will assign us.
Yes, you are the team leader, Mariam and Foggy. You are the team leader, and that's why I'm letting you like giving the orders, whatever you want, and discuss the case. So you are working here as a team leader.
Okay, we'll check the vitals of the patient.
All right. So patient came, moved to the bed. So first you need to connect to the monitor and get a set of vitals exactly. You need to put 2 large IV lines. You can start off bolus of fluids and take blood. And at this time, you can activate the trauma code. So do you want to know the vitals?
Yes.
All right. So this patient vitals were, he was tachycardic of a heart rate of 120. Blood pressure was 123/55. RR respiratory rate, which was 34, and oxygen saturation was 86 on room air. So this is the vitals. Do you want to activate trauma code or no?
Yes, I want to activate trauma code.
All right. So trauma code was activated at this time. And do you have any idea who's part of the trauma code?
The anesthesiologist and the radiologist, the cardiologist, maybe the neurosurgeon, and the general surgeon.
All right. Cardiologist and neurosurgeon, they are not part of the trauma team. The trauma team usually include the ED consultant or specialist, or the ED resident, the general surgery resident, the anesthesia, the radiologist and radio technician, and the orthopedic and the ED nurse and ED nurse supervisor. Yes. So these are the trauma team. So traumatic activated, the team was there within 5 minutes. You have all the team availability and you assign the roles. So anesthesia take the airway, the general surgery took the primary survey, and you are leading the team as an ER. orthopedic was there, and the nurses were there taking the IV and putting the IV medications. All right. Temperature also was normal for this
Doctor,
patient.
before moving,
Yes.
Dr. Wadah, before moving on, like, we want to know what is the general status of this patient? We said the vitals and the team, but like, is he actively bleeding? Is he conscious? Is there
All
any
right.
sign of intoxication?
So now we will go through this should take like within less than 1 minute. The transfer and the vitals should be within 1 minute. And as you know, we are a team. So when you assign someone for the vitals and monitoring, the other one of the airway should be like starting managing the airway, intervening. So as a team, we work simultaneously, not step by step. But here we have to go step by step to make it easy.
Okay.
So all right. So now we have the vitals. We transfer the patient and the team is ready. So what do you want to do next, or what should be done next?
The primary survey.
All right. So primary survey. So in the primary survey, we'll check what was the status of our patient, and we should check what should be done, or what are the critical diagnoses that we should interfere and manage at the primary survey. So primary survey, what does include?
The airway, the ABCDE.
All right. So primary survey is a systematic approach that go through the ABCDE. And airway, what's the airway?
So we check if the patient is, for example, if he was talking, so the airway is patent.
All right. So our patient was not talking; he was just moaning.
Okay.
We check if there is any obstruction, obvious obstruction, or stridor, signs of upper airway obstruction.
All right. So there as an anesthesiologist, he checked and he told you there is no airway obstruction and there is no foreign bodies, no secretions, no blood in the airway.
Okay. So then we need to move to B, the breathing.
All right.
I think we need to intubate this patient.
All right.
Before moving
So
into B.
okay. So this patient, as you told you, there is no airway obstruction, but he was not talking. He was mainly moaning. There was no signs of foreign body in the airway. There is no bleeding, no secretions. And also part of the airway, you have to look for maxillofacial trauma and neck trauma that may indicate airway compromise. There was nothing in this patient. And as you said, there is no snoring, no gargling, and no stridor or hoarseness. The other more important thing in the airway is to make sure that the C collar, it's in the ABC mnemonic is airway with C collar. So if there is no C collar, you have to apply a C collar. All right. And you examine the neck. If there is any tenderness, there was no tenderness, and there was no tracheal deviation. So this patient, as you said, in the vital saturation was 86, and part of the airway, there is no airway obstruction, but we have to do this patient, how to interfere before intubation.
We will give high flow oxygen.
All right. So high flow oxygen. Anything else?
Do the jaw thrust and head tilt maneuver for him.
All right. So usually in trauma patients, we should not do the head tilt, which is the active hyperextension of the neck. We can do just the chin lift or jaw thrust. Yes. And
we applied C-collar as well.
Yes, C-collar was applied by the EMS, and it was there. And if needed, and saturation is still not improving, you can put the nasopharyngeal airway, as the patient is not unconscious, he's semi-conscious. So he was moaning, and but he's opening eyes. So we'll go through the GCS later on. But at this point, do you think patient needs intubation before going to the secondary? I mean, the primary, other parts of the primary survey?
Can we have like a set of vitals before, after giving the high flow oxygen?
All right. So after applying the maneuvers and high flow oxygen through the breather mask, his saturation picked up to 90s, and other vitals are still the same. Still tachycardic, tachypneic, and blood pressure was stable, 120 something over 53.
At this time, I don't think that we need to intubate this patient.
All right. Okay. So I agree
We
with
just
you. There
needed
is
to prepare for intubation if he needed so, but at this time we don't need, like, can move into B.
yes, sure. So we consider intubation at this patient because he was desaturating, but it's improved with the non-breather. But at this moment, it's not part of the it's not indicated emergently at this moment as per our as per our decision. But we moved to next part of the ABC or primary survey, which is what is it?
The breathing.
Okay. So breathing. What do you want to check in the breathing?
I would like to check if the patient was breathing spontaneously, if there was any chest movement while breathing, and I would like to use my stethoscope to listen to his heart, to his lung.
All right. Yes. So as you know that as we learned in medical school, and we know that in every examination you have to go like inspection, palpation, and auscultation or percussion if needed. So in inspection, this patient breathing pattern was in the right side was asymmetric, which include that left side was moving with the inspiration expiration, but the right side there is part of it that is not moving with inspiration. The other thing, there was no bruises, and part of the breathing, the saturation was, I said, it's 90s, 90, 91, and RR was still tachypneic of 34. We palpated for any tenderness or subcutaneous or any subcutaneous emphysema, which was not there in examination. We auscultated for the breathing, and there was decreased air entry on the right side. So yes, these were the findings in our
What
patients.
about
So,
percussion? What about percussion and trachea?
okay, so trachea was in the midline, was not deviated, and percussion was not done at that moment.
Okay, so now we're suspecting pneumothorax. So we need to intervene immediately by putting chest tube.
All right, so it's what type of pneumothorax, this one?
It's a simple pneumothorax.
Okay,
Simple
so good.
pneumothorax.
So how do you know, do we need to intervene for simple pneumothorax at the primary survey, or it's not, or if it's only
No
tension
need
pneumothorax?
at this time.
Sorry?
Tension pneumothorax is more dangerous. I think simple pneumothorax, we don't need to intervene at this time if we have like a more severe issue with C, like active bleeding or something.
Yes, exactly. So this patient has decreased air entry. There is, as we said, there is asymmetric movement of the right chest. So it could be there is like tension pneumothorax. I mean, it could be like simple pneumothorax, hemothorax, or it could be just contusions and rib fractures. So you said tension pneumothorax. How to define or how to know this the patient has tension pneumothorax or not?
If he was vitally unstable and if there was tracheal deviation as well.
All right. So tension pneumothorax, as you know, it's one-way valve which air leaks from the lungs to the pleura, which lead to lung, to collapse and increase intrathoracic thoracic pressure, which will lead to decreased venous return to the heart and shock and hypotension. This patient, fortunately, alhamdulillah, he wasn't tensioning at that time. Okay. So, what are the signs of tension pneumothorax? Which is the signs of tension pneumothorax is tachypnea, patient will be tachypneic, desaturating, and respiratory distress, hypotension, and absent breath sounds on one side, and usually the neck veins will be distended and trachea deviation. But one point here, the trachea deviation is very late sign, and it's not always there for tension pneumothorax, and it's not needed to diagnose tension pneumothorax. All right. So let's say this patient has tension pneumothorax. What will you do? How do you manage this patient?
I would immediately put a needle.
All right. Where to put it?
In the fifth intercostal space, mid-axillary line.
All right. So yes, as you mentioned, this patient is an adult patient. So needle should be inserted. If patient has an tension pneumothorax, needle should be inserted in the fifth intercostal space, slightly anterior to the mid-axillary line, and the thing, the length of the needle should be at least 8 centimeters. Okay, so it will reach the pleura. If there is none of this characteristics of this needle, which is large bulge and 8 centimeter, you can do what we call it finger thoracostomy. You just open and insert your finger. All right, and then you have to do what?
After that, we can place the chest tube.
Yes. So after the finger thoracostomy or needle decompression, you have to put the chest tube. All right. So fortunately, this patient doesn't have a tension pneumothorax, as his blood pressure was maintained normal throughout. So what other differential could be like? This patient had decreased air entry in the right side and no movement of the right side.
He could have hemothorax.
Yes, hemothorax. And if there is a simple hemothorax, it's fine. You can leave it later and treat it later. But if there is a massive hemothorax, which is part of the primary survey, we should manage it. So what do you mean by massive hemothorax?
I mean blood filling the pleural cavity, compressing the lung.
Yes.
So there will
And the
be
patient will be vitally unstable.
Yes. So as tension pneumothorax, also massive hemothorax, which is accumulation of blood, minimum 1.5 liters, that will lead to, as you said, compress the lung and desaturation, hypotension, and also in contrast to tension pneumothorax, in this patient the neck veins will be flat because it's a hemorrhagic, so it's a hypovolemic shock.
yes.
All right. So how do you manage this patient if he having a massive hemothorax?
Insert a chest tube.
Yes, exactly. So this patient needle decompression is not working here as in massive hemothorax. So the treatment of massive hemothorax is chest tube insertion, which is usually large chest tube from 28 to 34. Where to insert it?
It's in the same place, fifth intercostal mid-axillary line.
Yes, so it's in fifth intercostal space anterior to mid-axillary line, or it's like slightly anterior. So okay, so let's say you put the chest tube for massive hemothorax, and what do you need to check for, or what do you need to monitor?
Blood pressure.
Okay, blood pressure was stable. So after putting a chest tube for hemothorax, you have to calculate what was the drainage, how much was the drainage. Because if there is like specific amount of drainage, you need to do what? Thoracotomy. So not by ER, but by the surgeon or thoracic surgeon. So if the drainage was more than 1.5 liter at the moment of putting the chest tube, or more than 200 ml per hour for 2 to 4 hours, this is indication for thoracotomy. All right. Okay. So alhamdulillah, our patient didn't have massive hemothorax. So the other critical diagnosis in breathing is what, or could be a differential in this patient, which has like decreased air entry in the right side.
Lung confusion.
Okay, could be lung congestion, or could be the other one, which is open pneumothorax. Yes.
Yes.
All right. So open pneumothorax, which we call it sucking chest wall, which is really due to penetrating injury at the chest, could be like anterior or posterior, where the air enters the pleura with each inspiration. So it will accumulate and it will lead to lung collapse and also hemodynamic instability. Signs and symptoms are the same. And what's the management of open pneumothorax? If you found one,
Dressing.
what we call this dressing?
I think compressing dressing or something like that.
Okay, so in patient who is having like a sucking chest wall or open pneumothorax, we put three sides occlusive dressing. All right, so it should be from 3 sides. You know why?
No.
Because the air will we want the air to we want the air to go out but not to go in. So
Exactly.
there have to be a valve.
Yes. So if you put from the 4 sides occlusive dressing, this will transfer the open pneumothorax to attention pneumothorax. So we put it on 3 ways, 3 sides occlusive dressing. So there is one side which will open. So whenever the patient will inspire, the occlusive dressing will collapse and will prevent air from entering the pleura. And whenever the patient is expiration, the air will go up from the pleura. All right. So that's why you close from the 3 sides. And next, what will you do after the dressing? For open pneumothorax? Any
Chest
idea?
tube incision.
Yes. So after you do the 3 sides occlusive dressing, you have to insert a chest tube for the open pneumothorax, and it should be not at the same side of the wound, like a bit away from the wound. All right.
Okay.
Okay. So now you know what in the breathing you have like decreased air entry on the right side with the with the decreased movement of the right chest, and we just put the patient in a breather mask, and the vitals was stable, and he was maintaining saturation at that time. And do you want to do anything else at this time?
We can move to C.
All right. So moving to the C, what do you want to do in the C or circulation?
I would like to check the pulse of the patient right now.
Pulse was normal in all extremities.
And what about the blood pressure in this moment?
Blood pressure still, as in the earlier, it was 120 over 55.
Can we listen to the heart sound?
Yes, heart sounds were normal, S1, S2. There is no muffled heart sound. There is no any murmurs or whatever. Usually we don't hear murmurs in the, especially in noisy environment, but there was no muffled heart sounds. They were normal.
Okay.
So we
We'll
exclude
ask.
tamponade.
Sorry?
So we can exclude tamponade, like it's not in this patient.
Yeah, so there is no muffled heart sounds, and vitals are okay. I mean, the blood pressure is fine. So it's less likely patient to be tamponading. Okay. So
We'll ask
can
the
we,
nurses to insert 2 large IV line.
okay, so IV lines are already inserted. 2 large IV lines were inserted in the initial treatment or initial management of this patient.
Okay, and we will start giving him 1 liter of normal saline.
Yes, the first 1 liter is already going on.
Okay.
What else you need to look for in circulation?
Neck veins.
Okay, neck veins were normal. They were not distended or they were not collapsed. All right,
We
so
listen to the base of the lungs.
To check for what?
Signs of heart failure.
Okay, so we are not expecting patient to be in heart failure right now. Is an acute trauma. Anything anyway. So another part and another thing in the circulation which you check for, there is any external bleeding. So this patient doesn't have any external bleeding, and no obvious bruises in the abdomen, or there is no long bone deformities or pelvic or bleeding from the urethra. As we said, blood pressure was normal, heart rate was 120, and pulses were intact in all extremities, and examining the pelvis was stable. So this patient, do you think he's in shock or no?
He's not.
He is not. Why?
Doctor, I think he is not currently in shock, but he will be, like, if we didn't intervene, because if we calculated the index, it will be 0.97, which is like in the in the upper normal of shock index.
Okay.
So maybe he have a hidden shock.
All right. So do you know what are the classes of shock and or hypovolemic shock in patient with traumatic patient?
No.
Okay, good. So we have 4 classes of shock, which is class 1, class 2, class 3, and class 4. Usually class 1, when the blood loss is less than 15% of the patient blood volume, okay? And usually this class is asymptomatic. So heart rate will be normal, blood pressure will be normal, pulse pressure will be normal, respiratory rate and urine output and GCS will be normal. All right. So this patient could be in class 1 shock. All right. Or you could be in class 2. So what's class 2? Class 2 when the blood loss is from 15 to 30% of the patient blood volume. And this class 2 heart rate will be increased, which was here in this patient, right? So this patient heart rate was 120. Okay.
Yes.
So and the other thing, blood pressure was in class 2 should be normal. So when we say hypovolemic shock in trauma patient, does not mean the patient should be should be hypotensive. So it could be like asymptomatic or vital were normal, or could be just tachycardic, which include class 2. But if the patient is hypotensive, this will be class what?
Sorry?
This will be so this will be class 3. So class 3 when the patient blood loss is from 31 to 40% of blood volume or total blood volume. So this patient was in class 2. He was tachycardic. Other vitals were normal, and we said if he is hypotensive, this will be class 3 hypovolemic or hemorrhagic shock, and class 4 usually patients will be tachycardic, severe tachycardia. There will be severe hypotension. Urine output will be decreased and just minimal urine output, and GCS will be altered, and it will be like lethargic in class 4. So to make it easy, so patient with class 1 can be normal. Patient with class 2 usually will have heart rate will be increased and pulse pressure will be narrow. So do you know what's the pulse pressure?
The differences between systolic and diastolic.
Yes. So in an early shock or when the bleeding, when there is a minimal bleeding, the blood tries to compensate by increasing the diastolic pressure. So the difference between diastolic and systolic pressure will be narrow. So this will be like in class 2 shock. Class 3 patient will be hypotensive, okay, and urine output will be decreased a little or could be normal. Class 4, the patient will be tachycardic, will be hypotensive, and the urine output will be dramatically decreased, and the GCS will be affected, so patient will be lethargic. All right. Class 3 patient could be confused, but class 4 he'll be lethargic. Mean like just arousable. So in class 1 and 2, there is no immediate indication for blood transfusion. You can give fluids. Class 3, there is indication for blood transfusion, and usually class 4, they will need massive transfusion protocol because they lost more than 40% of their blood. Right? Clear?
Yes, clear.
Yes.
Yes.
So the classes of shock and trauma patient is very important, and we have to know them. The other thing, the other mnemonic, which we say like in circulation, you have to look for bleeding, which is like in the floor or 4 more. So in the floor, if there is any external bleeding, 4 more, which indicate really the where the blood can accumulate for large amount of blood, which is usually the abdomen, the chest, the pelvis, and long bones. All right. And yes, so in this patient, you said he's in class 2, right? Is class 2 hemorrhagic shock or hypovolemic shock. So what will you do for him?
No need for immediate intervention.
Okay.
We
But
already give 1 liter of fluid. We can give the
yes,
second liter, and we can prepare for transfusion, like we can do cross match, type and cross match.
yes. So we'll come to the investigations in the trauma. Yes, a part of it, which is type and screen or type and cross match. And as you said, 1 liter of fluid's already going on. So do you want to give a second liter of fluid?
Yes.
All right. So as per the ATLS, IV fluids is not anymore recommended to give 2 liters of IV fluids. It's recommended only to give 1 liter of IV fluid for different reasons. First thing, that if there is bleeding, the patient is losing blood, not fluid. All right. So if you want to give, you can give blood. The second thing, when when the patient maybe had like a bleed from vein or whatever, and there is a clot developed, right? So the system will try to prevent the bleeding, so a clot will be developed. So if you give like too much fluid, this fluid will dissolve the fluid, and the bleeding will this fluid will dissolve the clot, and the bleeding will reoccur again. So it's recommended not to give more than 1 liter of fluids in traumatic patient. And if you still think the patient needs more, you can give blood. All right, or try to check what is the source of bleeding and stop it. So these are the usually treatment and circulation, which is only cautious fluids, resuscitation maximum of 1 liter, blood transfusion if needed, and control the source of bleeding either in the AIR or OR. All right.
Okay.
Good. So we are done with the C. Anything else in the C you want to do or you want to check?
We can move to D.
Doctor, you said that there is no external bleeding, right?
Yes, no external bleeding.
Okay, we can move to D.
Or maybe we can part of the C we can check EFAS quickly.
Yes, exactly. So in the ATS, still AFAS is not part of the circulation, but I think maybe in next recommendation it will be, because as and it's now practiced. I mean, in many institutes that part of the primary survey, which is the AFAS, and especially it's done during the C.
Yes.
All right. So to check if there is any internal abdominal bleeding or whatever, or there is any hemothorax, or if there is bleeding in the abdomen or cardiac tamponade. So the FAST was done at this EFAS was done at this moment during the C by general surgery resident, and it was negative. There was no intra-abdominal bleeding, there was no tamponade, and they didn't see any hemorrhagic or hemothorax.
Perfect. We can move to D.
All right. So D. Good. So what do you want to check for D?
I would like to know the GSS of the patient.
Okay. Can you be more specific? What GCS or what parts of the GCS? So I can give you the answers.
Okay. Does he open his eyes spontaneously?
Yes. Patient was opening eyes spontaneously.
Okay. We can put it as 4. Do he speaks?
No, he was just moaning.
Moaning. It's like an inappropriate sounds. 3.
Yes.
Okay. Or a 3 or 2.
Okay. So inappropriate sounds is 2.
2. Okay. Yeah.
2.
Yes.
And then could he
Does
localize?
he move?
Sorry.
Okay, Mariam, go on.
Does he move his limbs on command?
No, he's not moving. He's not listening to commands.
Could he localize the pain?
Does he look what?
Localize the pain?
Yes. So when we put the pin in his chest, he was localizing it and trying to move my hand from putting the pin in the chest.
So it's 5.
Yes.
Okay.
So what's the total GCS for this patient?
11.
11.
All right. So when patient is GCS is low, there should be like mainly 2 reasons. Either he's in hypovolemic or hemorrhagic shock that decrease the transfer. I mean, there are multiple reasons, but mainly in our trauma or our main differentials could be like he's bleeding and the blood is not reaching the brain, or there is head trauma or head injury. Okay.
Yes.
Other differences could be like hypoxia, could be like alcohol, could be like he's intoxicated or whatever. He takes some medications. But these are the main things that we have to make sure that he's not bleeding and there is no head injury. All right. So what else in the D? So GCS was 11 out of 15.
pupil size and reactivity?
Yes. So pupil size were normal, maybe 2 to 3 millimeter, and they were reactive to light.
Okay.
Anything else?
Since he is in pain, I think we can do a pain assessment for him.
Okay, so patient when he came, he was in severe pain. So I forgot to say that, but usually in initial treatment, when you give two IV lines and you give like the first liter of fluid, analgesia should be given at that time because you don't want patient to suffer the whole examination. So analgesia, strong analgesia, which was morphine, 5 milligram, was given initially at the initial treatment.
Yeah, and doctor, we need to check his temperature as well. What is his temperature?
So temperature is usually part of E, which is the exposure. But in D also we said like the GCS, the pupils, we also should look if there is any lateraling signs.
Glucose.
What do you mean? Yeah, glucose and lateraling signs. So what do you mean by lateraling signs? So let's say maybe the patient is moving only the right side, not the left side, or maybe there is like angle of mouth deviation. So these indicate the patient maybe is
Facial drop.
yes, or facial drop. So if there is any lateral signs, indicate there is like anything, maybe head trauma, and there is like stroke or dissection or whatever that caused patient to have lateral signs, which is part of the D. The other thing which we check the glucose. Part of it is the glucose, which was normal in our patients, and the patient doesn't have any lateral signs. All right, we are done with the D. So do you want, we said like it could be like hypovolemic or bleeding or head injury. So what you can do for a head injury patient in the ER? I mean, how do you manage head injury? Of course, we are not a neurosurgeon. We are not
suspected. Like, do we suspect increase in intracranial pressure?
It can be, though there is no signs of like Cushing triad or patient was not vomiting. It's less likely, but it can be, or could be like early. But yeah, what else we can do?
Doctor, I think after finishing our primary survey and make sure that the patient is vitally stable, we can send him to the CT to make sure that there is no hemorrhagic shock, for example, or hemorrhage in the brain.
All right, so we are still in the primary survey. So as part of the D, and if you suspect head injury, especially with low GCS, as in head injury, the thing we can do in IR is we prevent secondary damage, okay, or secondary injury, which usually happen due to hypoxia, hypotension, hypoglycemia or hyperglycemia. Yes, hypovolemia. So we have to make sure that we optimize the patient to prevent secondary damage or secondary injury to the head. All right. So patient was vitally stable, was not saturation. He was hypoxic, but saturation is okay with the null breather, and glucose was normal. So now moving to the last part of the primary survey, which is
E,
which should include what?
Exposing the patient and looking for any extra damage.
All right, yes. So patient was completely undressed and full examination was done. Leg roll also was done, which was there was just mild tenderness in the lumbar area. And digital rectal examination was normal, the digital rectal exam. And then don't forget at this moment to check the temperature, or you can check it with the vitals, and try to avoid hypothermia. So when you examine the patient, when you undress the patient, you have to put him in blanket or bear hugger, which is some warm cover or whatever, so to avoid hypothermia, because it's critical and it could like lead to worse outcome if the patient being hypothermic in the ER. Okay, so we are done with the primary survey. We found some abnormalities, so we interfere. So what we can do now?
Okay, we want to check his vital again.
Right, yes. So part of the primary survey is usually reassessment. And if there is any deterioration, you have to reassess again from A, B, C, D, all right? And the other thing, if you did any intervention like chest tube or whatever, you have to go back and assess A, B, C, D, E always. All right.
Yes.
So vitals, as we said, they were maintained throughout the primary survey at the same level. Blood pressure was still 120 over 50s. Heart rate still tachycardic, with the split improved with the saline, became like 110, 112, and saturation was still 90, low 90s.
Yeah.
Anything else?
So I think we can move the patient to the CT, trauma CT.
Okay. So before moving the patient to the trauma CT, anything you want to do in the recess?
I'm not sure.
So yes, we have what we call the adjuncts, which is the adjuncts to primary survey, which usually include the chest X-ray, pelvic X-ray, and EFAS if not done in the circulatory part. And patient should have urinary catheter and NG tube or OG tube.
Yes.
All right. So we did a chest X-ray as part of the primary survey and adjunct, and you can see the chest X-ray.
Yes.
So this is our chest X-ray, which was done in the ER. What do you think? What was there?
I think that there is lung contusion in the right side.
Mm-hmm.
Okay. Filled with the fluids.
Okay.
There
Which
is
is
no
usually hemorrhage. The fluids in trauma is hemorrhage.
yeah. There is no tracheal diffusion.
Mm-hmm.
The diaphragm is not aligned.
Okay.
I think maybe it's hemothorax.
Okay.
There is
So,
a scapular fracture on the right side as well.
yes. So there is a scapular fracture, community scapular fracture, there's a and clavicle. So there's a community clavicle fracture, and there is lung contusions, and apparently there is like some heaviness in the right lower lung, so it could be like most likely it's a hemothorax. The other thing, there is multiple rib fractures in this patient. So, and especially if patient has scapular fracture, that means that the mechanism is too severe, and we suspect that there is thoracic injuries. All right. So this patient, after the chest X-ray, with the hemothorax and with these fractures, and if you can see, it's not clear here, but he had multiple rib fractures at 2 points. So what we call this thing when you have multiple more than 2 rib fractures at more than one side?
You can say maybe flight jet.
Yes. So this patient had flail chest, and this was what the cause why the right, part of the right side of the chest was not moving with inspiration. So this patient with flail chest with the hemothorax and saturation of 90%, and it was less than 90, and room air it was 86. So what do you want to do for him? And this is the chest X-ray.
Occlusive dressing followed by chest tube.
Occlusive dressing for what?
For the flail chest.
Okay, there is no, I don't know, there is any, I don't know, there is, we should do occlusive, but it shouldn't, and it's not part of the treatment of flail chest. So flail chest, mainly the treatment of it is like oxygenation of the patient. So you have to give him a patient already non-breather, and if he's still not picking up with the non-breather, you have to intubate this patient, and especially indication for intubation in flail chest if the oxygen saturation in room air is less than 90%. So this patient was less than 90%, and he had a flail chest, and with the non-breather, the oxygen saturation is still 90%. So, and he had like hemothorax, and so this patient was intubated. And so at that time, the decision was to intubate. So we didn't intubate the airway in the primary survey, but with this flail chest, with desaturation and not picking up enough with the non-breather, so this patient was intubated. All right. So while intubating, yes.
Since he was semi-awake, we can sedate him or induce him for sedation.
Yes.
Before intubation.
All right. So that's what you call drug assistant intubation, or RSI, which is rapid sequence intubation. So patient went through rapid sequence intubation. He was sedated with etomidate and fentanyl given as analgesic and sedation, and succinylcholine was given, and patient was intubated. So after intubation, and as you saw in the X-ray, right, there was a hemothorax. Yes.
Yes.
So what will you do for this hemothorax?
We'll insert a chest tube.
All right. So the chest tube was inserted by the ER resident, and while inserting the chest tube and patient is already intubated, patient deteriorated. Before the intubation, also patient deteriorated and GCS dropped to 8. This was another indication for intubation. So what's the GCS point of intubation, like when to need to intubate the patient?
If it was below 9 or below, yeah.
Yeah. So if it's less than 8 or less, patient will need intubation. And as we said, the other indication is the flail chest with desaturation.
Doctor, I have
Okay.
a question.
Yes.
If it does the flail chest and his saturation is within 90s with non-breathable mask, like I don't see that he needs intubation unless if the GCS was 8. But
Yes.
like if he just had the flail chest, why we risk the patient for like intubation complications when we can manage it with something else?
All right. So I totally agree. Flail chest by itself is not an indication for intubation, and we should not intubate patient for flail chest only. But if the patient has, especially in this patient, he was hypoxic, saturation was 86 in room air. So as per the ATLS, if patient has flail chest with hypoxia, which is you can do an ABG, which BO2 is less than 60, or saturation room air less than 90, these are indication for intubation in flail chest. Okay, at least temporary intubation until the patient, it's getting strong analgesia like intercostal regional block, or the epidural analgesia or whatever. So the patient was intubated, as I told you, because of these two reasons: the GCS dropped to 8, he was not opening eyes except for pain, and for the flail chest with desaturation and hypoxemia. And so we inserted the chest tube, and while inserting the chest tube, patient blood pressure dropped to 80, as you can see it. So what will he do?
We will give him blood and crust O positive blood or O negative.
O negative.
So we said whenever we have deterioration, we should go back to airway breathing circulation. So ABCD again. So this patient blood pressure dropped to 80/45. So we went back airway. He was intubated with saturation back up to 97, 98 with ventilation. Breathing, there is no changes. And the chest, and the chest tube was inserted the right side, and there was better air entry in the right side. Circulation, as you said, blood pressure dropped. So what you can give?
Blood transfusion with O negative blood if he wasn't crossed yet.
Okay, so patient was not yet crossed, but why you want to give O negative?
Because we don't know the.
I think if it's a man or a woman that is not in the child bearing age, we can give O positive.
Yes.
But if it's a woman in the child bearing age, then it's need to be O negative.
Exactly. So woman with childbearing age, or child less than 12 years, we should give O negative. Otherwise, we will give O positive, because we don't have too much O negative. So this patient was given 2 units of blood O negative through forced infuser, and after the blood pressure improved to 95 and 100. Okay.
While giving the blood, can we check the amount of blood that was drained from the chest tube?
It was minimal, just maybe around 50 or 100 ml that was drained from the chest tube throughout his stay in the ER.
Okay.
Okay.
I think
so
now we can redo the E-FAST because
Yes, exactly. So EFAS is not one-time procedure. So whenever like if there is deterioration or anything, it's part of the ABC. So you have to do the EFAS. EFAS was done again, but this time by the consultant ER, and also it was negative. Nothing in the EFAS.
Okay.
So what do you want to do at this time? So we are done with the primary
what is the
survey.
blood pressure?
Blood pressure, we said it's improved to 100 over 50 or over 60.
Can we do CT?
Okay. So before CT, you have to do the secondary survey, right?
Yes.
So CT scan is adjunct to the, as we know that chest X-ray and EFAS is adjunct to the primary survey. CT scan is adjunct to the secondary survey. So what's the secondary survey?
Head-to-toe examination plus history if we can get it.
Yes. So head-to-toe examination, and our patient was negative. Other than things we found in the primary survey, which is mainly in the chest. Otherwise, it was normal. And the sample history, patient was intubated, and we could not get the sample history. And since the beginning, even he was moaning, and he was not giving any history. All right.
No collateral or.
No collateral. So as per the EMS, this patient was found in the car, and it was rolled over, and the top of the car was down, and it was in the second seat passenger, and he has a driver also, which was also in trauma patient, which was moved to the, but he was more mild, so he wasn't moved to the resus. He was moved to the treatment area.
We can get the history from them.
Okay. Yeah, we can do that, but I mean, during this time, you don't have the time to take the history to go to the treatment area, which is also like not, it's a bit far, but we can, ask for, one of your team to go and take a further history.
Student.
Okay, what what happens? Anyway, so yes, so we had done the primary survey, we did with the secondary survey, we intervention when we needed. So you were asking for CT scan. So can we see the CT findings? Okay. So the CT here, what do you see in the CT of the chest?
So there is clearly lung contusions on the right side with or fluid accumulation as well. But since it's in the upside, we can say that it is air, not the fluid. Right, doctor?
So which one is the right side? So which one is the air? Which one is the fluid?
The black one is air and the white one is fluid.
White one is the blood.
Yeah. So in the top there, on the right side top, there is a pneumothorax. It's usually the air and patient lying supine, so the air will be upside, and the hair and the anterior to the ribs or the back, there was a hemothorax, and it's already managed. The chest tube was there, and the saturation was fine after intubation and chest tube. And the CT head, if you can see it. So this was the CT head, what you can see there.
There is no clear...
There is like multiple focal lesions, and I think there is an obstructive hydrocephalus because we can't see clearly the ventricles.
Yeah, I think the hydrocephalus, I mean, the obstructive is because of the, the cut is what, it's not the proper cut for the, to see the ventricles. But clearly you can see the hyperdensity lesions, which is here, almost like 3, 4, 5 lesions, which in this patient indicate there is a hemorrhage, intracerebral hemorrhage or bleeding inside the brain. So this may, explain his low GCS. So, okay, so we did the CT, patient came back from CT, chest tube was inserted, patient is intubated, ventilated, and saturation is okay, vitals are okay now. So what will you do next for this patient?
So since we have intracerebral hemorrhage, we are expecting that the intracranial pressure will increase. So we do like we will raise the head of the bed. We can give mannitol or hypertonic saline, and consult neurosurgery, of course.
Okay,
And,
yes. So neurosurgery was consulted and was informed about the CT findings. But for the and if you can see in the CT or it's reported in the CT, there was no herniation. So at this time, there is no need for mannitol or hypertonic saline or hyperventilation to manage this hyperdensity lesions. So just
Doctor,
neurosurgery
like,
consulting. Yes.
if we waited and we didn't do anything, like the intracranial pressure will increase eventually. So shouldn't we prevent it before it's secure?
So as we said, to prevent secondary injury in the head, you have to make sure that blood pressure is normal, patient is glycemic, and there is no hypoxemia. But we cannot, give the, this like medication, which is the mannitol and hypertonic saline for a patient who is still, and there is no indication for it. Patient is not herniating. You can raise the bed a bit, you should raise the bed 30 degrees. And we consult neurosurgery, which was there and immediately. So they have to manage their part of the trauma. I don't think if Dr. Aisha Mamri has any comment or anything about it. If you need to give this one before, if there is no herniation.
عفوا دكتور, بس can you repeat the question again?
So she was Dr. Mariam or Dr. Hoggy. She said this patient has hyperdensity lesions, and we should give mannitol and hypertonic saline to prevent intracranial pressure increasing. But it's patient is not herniating. Do we need to give? I don't think we need to give this medication.
No, you are right. So the way you think about brain injury, you have primary brain injury, which is the lesion you have seen, which is likely the concussion and the contusion. And then you have secondary brain injury, which you try to prevent. So by preventing hypothermia, hyperthermia, by preventing hyperglycemia, hypernatremia.
For me, the sound is not clear. Is it clear for everyone else?
Can you hear me better now?
Yes, we can hear you, doctor.
We can
So
hear
in the ER immediately, as Dr. Waddah said, you will not give any agent to lower intracranial pressure except if you have evidence of herniation. So unequal pupil, for example, or any signs of lateralization, right? Or Cushing's syndrome, for example. So hypertension, bradycardia. Other than that, what you want to do is you want to protect the brain. So your targets would be to keep sodium normal, to keep normothermia, and to keep normoglycemia, as well as to keep CO2. So when you intubate and as you set the ventilator setting, you want to keep CO2 within normal, so somewhere between 32 and 35. So not overventilate and not as well hypoventilate and cause hypercapnia. So initially, like in the immediate reaction, you don't need to give any of the agent you mentioned.
Doctor,
Yes,
how about
exactly.
if we have intracranial hemorrhage and we are suspecting that around the hemorrhage itself will have brain edema? Do we give like, I read that
so if
because
hemorrhage, more or less the same principle.
edema.
So same principle. If you are herniating, that when we're gonna hyperventilate for a CO2 target, again 32 to 35, and when we will consider giving mannitol or hypertonic saline. If someone have evidence of herniation, but only having edema midline shift, but no evidence of herniation, then again you prevent secondary brain injury, and then you go for definitive management. So if it's epidural, you want to bring patient to OR, evacuate the hematoma. If it is subdural, more or less the same, because if you're saying there's kind of very hemorrhage edema or there's midline shift, then likely that will be an indication to evacuate the hematoma as well. I mean, we're talking about the context of trauma patient, right?
Yes,
not medical hemorrhage, because medical hemorrhage will be a little bit different kind of intervention practically.
Okay, thank you.
Yes, thank you, Dr. Aisha. All right, so this patient, so we did the CT and we managed everything we can do in the air. So what will you do next for this patient?
We can do blood test.
Okay, so blood test usually, as we mentioned earlier, in the when you put two large IV cannula, you should take blood for investigations. and yes, they're not that much important, except the type and screen and the coagulation and cross match. Yeah, these are the most important things, and the glucose, of course. But what other investigations you can do also, or you can tell the nurse to do?
ABG.
Okay, ABG to check there is a special patient was desaturation, to check for hypoxemia. Yes, ABG or VBG.
We should
CB,
also do
CBC.
another chest X-ray after intubation and chest drain insertion.
Yes, it was done, and intubation was, the NT tube was at the proper site, and the chest tube was also at the proper site, and the hemorrhage was a bit improved in the right side, the hemothorax. So okay, anything else?
I don't think that there are anything else other than stabilizing the patient and preventing further injury from happening.
Okay, so what will you do for this patient? You will just keep him in the AR, or where will you take him, to the OR, to the IR? Or?
At this time, we need to do like full CBC, and in case like the surgeons want to intervene, so we need to know the coagulation profile of this patient, and also like the COVID-19 PCR to not like.
Yes. So usually in trauma patient, the
investigation
investigations needed in trauma patient is usually as you said, the type and cross match, the CBC, the VBG or ABG, run the blood glucose, coagulation, especially if the patient is going to the or it's like part of the lethal triad, which is the coagulation, hypothermia, and acidosis. AFAS, which is usually done in the primary survey, the X-rays, and the CT scan, which is usually CT trauma from the head to the thigh or pelvis. These are usually the investigations done for trauma patient, and it was all done. All labs were normal. The CT findings were explained. The chest X-ray were explained, and the AFAS was also normal. Coagulation was normal. So patient at this time, he was vitally stable. He doesn't need to go to the OR, and there is no source of bleeding. So the patient was shifted to the ICU, which continuous management was done there by surgical team and the ICU team.
The neurosurgery as well. He has intracerebral hemorrhage.
So yes, neurosurgery, they came and they assessed the patient, and they, as you said, they just advised the head to be elevated, and to prevent secondary injuries, which is maintain blood pressure, maintain saturation, oxygen, and maintain the glucose level within the normal limits. Nothing was done at that time by neurosurgery, but the next day they went and inserted intraventricular catheter for monitoring. Yes, for monitoring the ICU.
Before shifting the patient into the ICU, do you think that he need like a higher level of monitoring, such as central veins monitoring or something like this, or he can be shifted to the ICU with the simple monitoring?
So we can do, and yes, this patient had, we did for him an arterial line to check to monitor his blood pressure, and for frequent monitoring of the ABG, he was intubated, and central line is not used to you can put a central line, but it's not for monitoring, just to give, patient needed fluids, he needed blood transfusion, he needed vasopressor. So for the medications, you can put central line, but all these things, it can be done in the AR or in the ICU. It's not an immediate intervention that it should be done in the AR.
Oh, okay.
Because patient was stable and he was maintaining his vitals, and that's it.
Yes.
Do you have any question regarding the case or any part of the case, or?
No, doctor.
No, thank you, doctor.
Thank you very much. You are a good team leader, mashallah, and you saved the life of this patient. And now, alhamdulillah, he's in the ICU. I think they extubated him.
Alhamdulillah.
يعطيك العافية دكتور وضاح. If I may just comment overall on the case and the discussion. So, mashallah, tabarak ar-Rahman, Dr. Waddah organized the case very well. And for Mariam Al-Fawaghi and the rest of the medical students, if you want to put this in a framework, simply what he showed you is approach to a trauma patient, any trauma patient, irrespective what injury they have. So a patient with a trauma who comes in, you should have an approach and you should have a mind map. So the mind map is what's simply in the screen there. So you start chief complaint, you prepare before even patient arrive, and then you look at your vital sign, your primary survey, secondary survey, and that kind of sort of approach. Tamam? So you want to have this mind map always in mind. So wherever you find a trauma patient, simply you carry on and follow the same map for any irrespective what injury they have. Tamam? الحين another note that I wrote is very well done for Fawaghi Miriam. Mashallah alaikum. You were taking decision as you recognize there is a problem. And that's one of the principles of managing a trauma patient. So when you do your primary survey, you find a problem with the airway, you need to stop and address it. Then you move to breathing, then to circulation. So you were already following that principle and trying to address problem as you recognize them. Now, one thing which you did very well with, given you are still at sort of medical school, like an advice I would say, irrespective what you plan to specialize in the future, it would be very useful for you to plan to do your life support courses, ACLS, PLS, PALS, and ATLS in your internship year. And that would give you the principle for managing acute problem, even if you end up specializing, let's say, dermatology or plastic surgery or any non-acute sort of even research, let's say non-clinical, but having that sort of mindset of approach to acute issues will help you as a physician in the future to address any clinical issue that may arise, whether in the hospital or outside the hospital. So another thing that I wanted to sort of point out, that when we teach trauma and when we teach approach, we go step by step, right? So give yourself a chance in your next clinical rotation, whether in the emergency department or any other clinical rotation, when there is resuscitation, whether trauma or medical, take a step back and observe how the action are happening. Action happen parallel. So A and B and C, we address them together, and it does not, in real life, it does not take sort of stepwise approach. Now it does in a sense that we think of them that way, but we act very fast, and usually your primary survey and whatever you do with it takes 2 to 3 minutes, صح؟ فبالتالي when I delegate the airway for one person, then I'm assessing breathing, and you might find us taking a decision in A and B at the same time. Then, so keep that in mind. It's a little bit confusing point when we move from sort of education to clinical practice, where we think of it, I need to finish A, then move to B, but then in reality, we do A and B and C at the same time. تمام? Now, indication for intubation. So Dr. Waddah had alluded to most of them. I would say just هذه احنا بالنسبة لنا in emergency medicine is very irritating when someone says GCS 8 I will intubate, GCS more than 8 I will not intubate. So this is such a classical traditional teaching. However, this point itself is not very correct. So I would leave it for you to explore and read and see if you find any evidence published around Glasgow Coma Scale and intubation. تمام? And as well, indication for intubation, Dr. Waddah mentioned most of them, but it would be as well up to you to go and sort of look up what are the three main clinical, the three main indication for intubation in any patient, not trauma patient only, but any patient, which will include trauma bad. I think that's all what I have. But mashallah, well done, very well prepared, Dr. Waddah, and as well taken by Maryam and Fawaghi, mashallah.
Thank you very much, دكتورة. يعطيك العافية.
I would like to thank all of our speakers for this informative and insightful discussion. We will open the floor now to the audience to share their questions and comments in the chat box. Okay, so we have a comment from Noura Baniya saying no questions. This was an excellent case discussion. Thank you all. So if we don't have any questions from the audience side, I would like to thank the speakers today, Dr. Waddah, Dr. Asha, Fawaqi, and Maryam for this comprehensive discussion. It was well taken from our side as well. It was very informative and enlightening. And I would also like to thank the audience for attending today's episode, and we hope we meet you all again next week. Thank you.
Thank you all very much.
يعطيك العافية. Well done. Thank you.
يعطيكم
Thank you
العافية.
everyone. Allah Hafiz.